Professor Stuart Mackey, Professor E.C. Vinayakumar, Dr. Vijay Krishnan, Dr. Srinivas Kishore, Professor Deenadayal, and Professor P.S.N. Murthy.
Showing the technique of doing different surgeries. So I will not go into the details of the techniques and the basic protocols. With the eminent panelists that we have here, Dr. E.C. Vinayakumar, Dr. Vinayakumar. If somebody can please go and call Dr. Vinayakumar. With the prominent panelists that we have, we'll try to get into some real life situations which you are going to get in day-to-day practice, and that will definitely make you a little better on when not to do things or when to follow our protocols. So basically for OSA, when we look at the anatomy of the oropharynx, it's not only the tonsils that we are looking at, it's the airway which is the lifeline of the patient, which can kill the patient if obstructed for just 2 minutes, is what we are looking at. And the airway is not only here, airway is behind this, airway is behind this. So the airway is right from here to here. So this is the airway we have to understand and discuss. So our discussion will start from the point when patient has come to our place, he has been evaluated, a sleep study has been done, and the diagnosis of OSA has already been made by either a level 1 or level 3 PSG, and either dynamic MRI, flexible, Mueller's, whatever one wants to has already been done. So once the diagnosis of OSA has been established, what next? What is to be done next? We'll start from that point. So the first question to the panelists. Anybody can feel free to comment. Can we have one more microphone there for everybody?
There is.
Do you always go for a weight reduction program before any kind of definite therapy? You have an obese patient. Do you always go without fail for a weight reduction program before any kind of definite therapy?
That patient can be started on CPAP and have adjuvant or concurrent weight loss whilst they're commenced on CPAP. You heard our first speaker today talk about a 10 to 15% change in weight or BMI, suggesting the likely requirement to re-titrate with CPAP. But you know, there's no point in wasting time if they've got significant degree of sleep apnea and starting them on positive airway pressure therapy, and they can be sent to the personal trainer or a weight loss expert concurrently. So weight loss is not just an only treatment for mild sleep apnea for people who are overweight. It's certainly an adjuvant or concurrent treatment for those patients who are being considered for CPAP or salvage therapy with a jaw splint or surgery.
So it's a very important point that just weight reduction is not enough. You have to start it concomitantly with either a CPAP, with a CPAP therapy concurrently.
The patient, what you're talking about, we need to evaluate this patient a little more.
Yeah.
Before you can come to a specific, what is the first step you need to take. So in that evaluation, what is the BMI? What is the anatomical findings in the nasal cavity, in the oral cavity? What is the main complaint with which this patient has come? How much is the AHI of the patient? Do you categorize them into a mild, a moderate, or a severe? If you program it into a mild case, I would definitely say go ahead, life change systems and lose your weight, and we'll observe and we'll see you. But if the patient is a severe obstructive sleep apnea case, then we are dealing like we are sitting on a volcano. So we would definitely say go ahead with the CPAP, and then later on we will look into life management.
Thanks. Anyone else? Okay, so if we put the patient on a weight reduction program, generally for how long, Stuart?
It's lifelong.
No, before giving him any definite therapy, 3 months, 6 months.
Well,
I like to wait. If he's not losing weight, then you proceed.
No, I think they're going to, if they've got significant sleep apnea, I think we establish that they get treated with CPAP and they can have adjuvant weight loss.
Perfect.
So there's not a large proportion of patients with significant sleep apnea that you'll say, go off and lose some weight and then come back and we'll consider other therapy. In the mild sleep apnea group with significantly elevated body mass index, then you might give them 3 to 6 months to lose weight before talking about other therapies. But moderate to severe sleep apnea should be treated when it's diagnosed.
So generally it's 3 to 6 months that you will definitely like to wait, but the treatment goes on lifelong. Yeah.
I would just like to add a point here. So when we are looking at two conditions, there are two different conditions again. Yes, they could be mutually complementing each other. Yes, obesity and sleep apnea do come together. But I think when the patient is coming to you with two diseases like diabetes and hypertension, so how can you just say that you are only going to treat diabetes and not your hypertension, even though your hypertension could be because of long-standing diabetes? So I think both of them need to be treated simultaneously.
Yeah.
Practically in our practice, we see two groups of people. Those people who are compliant and will listen to your advice and will take weight reduction on a very serious level. And there is a second group that doesn't listen to your advice at all. And these are the people, if you really go back into their history, they've been having this overweight problem for ages. So everybody would have tried something and it hasn't come down. So I would say for the first group that they have been, who are compliant, go ahead, give a 6 months period looking at their improvement. Then you have to tell them that they maintain it lifelong to see that that weight is maintained. But the group that doesn't reduce, you will know in 6 months' time, and then you have to give them some alternative therapies.
In practice, a lot of the patients in the milder spectrum, when you give them treatment options, will self-select out which treatment they want to investigate. But the important thing is if they opt for weight loss therapy without other treatments, that you surveil them and keep a close eye on them over time.
Okay, so this is a real life situation now. This patient is 30-year-old male, having snoring and is tired in the day. BMI is pretty high, 37. AHI is only 13. Nose has got a bad DNS and polyps with turbinate hypertrophy, adenoids, and the palate is thin and tongue is not bulky. Will be, in my practice, I would possibly not put him on a weight reduction program and simply go ahead and like to open up his nose. What is the panelist's opinion on this?
This patient needs treatment for his nose anyway. I mean, the treatment for chronic rhinosinusitis with nasal polyposis is a combination of surgery and long-term medical therapy to facilitate a patent nose and subsequent treatments that might be undertaken for his presumably mild obstructive sleep apnea if it's in the context of not significant oxygen desaturation, if all those events, for example, are hypopneas, and depending upon the scoring system that was used. He needs weight loss anyway because he's at significant risk of cardiovascular disease purely on the elevated BMI, even without the sleep apnea, but the combination of the mild sleep apnea and BMI might be even worse. So the ideal paradigm for this patient would be septoplasty, nasal polypectomy, functional endoscopic sinus surgery, adenoidectomy and turbinate reduction as a single procedure. I'm talking, we need more information, we need imaging and so forth, but as a single procedure, and then potentially long-term topical sprays to maintain the result achieved in the nose, and concurrent referral for weight loss, and then keep an eye on him and see how we are. The subsequent treatment potentially for sleep disordered breathing will depend upon the improvement after the nasal surgery and the weight loss. You wouldn't give him any guarantees about eradicating all of his sleep disordered breathing and all of his problems from the nasal surgery alone. And so subsequent treatment with a device or staged surgical intervention will depend upon the outcome from nasal surgery and weight loss in the first instance.
I think Stuart has put it forward very, very clearly. Anybody wants to add anything or should we proceed? Sir. Okay. So, in such a case...
मैं 155 किलो का हूँ और रात में मुझे कोई विशेष खुराकें भी नहीं आती और दिन में मैं बिल्कुल नहीं सोता हूँ सुबह 5:30 बजे उठ जाता हूँ.
For those who do not understand Hindi, he is 155 kilograms and he is saying that I am absolutely not sleepy in the day, I do not snore heavily in the night, and I get up at 5:30 in the morning and work till 11 in the night. Whereas this other patient...
I had a problem of sleep apnea for almost 7 to 8 years actually, but I didn't realize that I had this problem because I used to snore in the night, and I did this sleep apnea test the next day, and the results were not very good actually. I got up around 46 times in 1 hour's time, and my breathing stopped for 41 seconds as maximum, which was not really good actually.
So the message is that the earlier guy was 155 kilogram. This guy, you can see how thin he is. BMI is only 24, and he has an AHI of 46, and the maximum apnea time was 41 seconds. So it's not only the BMI. The message is that obesity is definite factor, but the BMI is not the only criteria that we have to think on. Okay, the second question is that do you always give a CPAP trial before taking a surgical decision? Always is the word. Any of the panelists?
Yes. I think you can summarise that with yes. I think that, and you know, there has to be very clear pathology of the airway, something like a thyroglossal duct cyst at the foramen cecum. You know, there has to be very clear pathology to warrant treating it, you know, without a CPAP trial when you're treating significant obstructive sleep apnea. You do get a feel sometimes for patients who have severe nasal disease who probably won't be able to wear CPAP automatically, but you'll be very staunch in telling them that we need to expediently do pre-phase nasal surgery and then move on to a trial of CPAP. And it's always very hard when you see patients with kissing tonsils and things like that as well, but they're a rarity. And I think that it's a very safe, it's a very careful, it's a very considered approach to give patients a proper and appropriate trial of CPAP under the guise of a sleep physician before endeavouring on a surgical pathway.
So if everybody agrees that we should give a CPAP trial, for how long? Before the patient,
for as long as it takes to decide whether the CPAP is treating their disease, which is almost 100% of the time, plus whether they are compliant or able to adhere to CPAP, or they have significant complications of CPAP. So the answer,
that period would be how long?
As long as it takes to figure that out under close surveillance. There's no time frame where you'd say we know, you know, there's no definitive time frame to say that this patient is CPAP compliant or not. Although I think if there's a prolonged period of time of several months, you know, 3 to 6 months, where there's absolutely no compliance, there's absolutely no supporting downloadable data, there's significant complications of CPAP, you're not going to let this drag on too long before you consider other treatment options.
So it's improper to give a 3-day trial from the company guy and the person not liking it, and you're saying that, okay, this person is not CPAP compliant. It's 3 to 6 months that you have to see what problem he is having, try to, you know, take away that problem and see that the patient is definitely not a CPAP compliant patient before we intervene for surgery.
And if there's nasal pathology, treat the nasal pathology and try again with CPAP.
Correct.
Can I?
Yes.
Can I comment? In our Indian scenario, this is a difficult option. In the Indian scenario, asking a patient to try the CPAP for a period of 6 months will leave you and go to another doctor. Let me be straight about that. I mean, I'm talking about the Indian scenario. This patient, when he comes, you advise a CPAP for a 5-day, call the patient after 5 days and ask exactly how he is feeling, and you will get the recordings from the CPAP itself, whether his problems have been settled. There is a percentage of patients who will refuse a CPAP. You can ask them to come again at the end of 1 month. Let them try it. These patients, when you tell them, take a trial up to a period of a month and make your decision whether you would like to go through a surgery or a CPAP, but your first choice is a CPAP. There is a percentage of patients who are going to come back to you and say, I would rather go through a surgery than a CPAP. 6 months period, in Indian scenario, this patient is going to go and take a second, third, fourth opinion, where the whole thing gets completely confused. The patient at the end of it doesn't know what he has to do. This is the Indian scenario.
Let me clarify by saying I would not see a patient and say you need to trial CPAP for 6 months. That's not what I would say to the patient. However, it is reasonable to say that you can try every possibility to adjust to CPAP over a period of 3 to 6 months before committing them to major airway reconstruction surgery. So that's an important point. The second point you touched on is also very important. There's a percentage of about 15 to 20% of patients whose uptake of CPAP immediately is zero. And then there's probably another percentage of around about the same who will tend to get distressed and give up on CPAP in the first fortnight to a month. And there's a variety of techniques to try and get those people to wear CPAP. The Scandinavians, for example, have taken to admitting patients to hospital for a 1 to 2 week period to get over the early speed bumps to committing to CPAP, and it shows that their compliance rates are greater. So should we be doing more? Well, it's within the context of available resources, really, what we can and can't do. But I think you've got to try everything you possibly can to get patients to commit to CPAP before proceeding down an airway reconstruction course.
So we have seen that there's a difference in the perspective of different situations and different parts of the world. Yes, sir?
Yeah, in my opinion, I'd like to differ a little. Now that this guy comes with huge tonsils and probably a bad deviated septum.
Same case I'm keeping again, sir. The same case which you saw, we have the same case. Will you still give him the CPAP trial? There is no place in the note for the CPAP. You have to go.
That's what he's saying.
On the other case.
Next case.
This is same case I'm keeping again. Will you give CPAP trial to this? He will not give because there is no place in the note. So there is no one rule that you can just learn and start practicing.
That's right. You can't. This is a heterogeneous disorder. The patients are all very different, and we have to individualise the assessment. But the primary treatment modality of CPAP tends to have a universality about it compared to our surgical techniques. So we have to try CPAP in these patients once they're able to, once their nose is patent.
Correct. So that's the message, that static obstructions possibly have to be removed, because even if you try to give a CPAP, the resistance to the CPAP, the air pressure required will be so high that the patient will not accept it. So generally CPAP trial is a must before every surgery, but only on dynamic obstruction. If there's a lot of static obstruction, possibly you have to just go and remove it. Like if a lady comes to us with a hearing loss, we just do not give her a hearing aid without removing wax. We know that wax causes almost 30 decibels of hearing loss, and from 70 with her wax she comes to 40, where she does not require a hearing aid.
But the corollary is it's very important to tell her you're removing wax to facilitate treatment for her sensorineural hearing loss. The same way we're improving the nasal airway to facilitate treatment, and there's potential outcomes that you need to talk to the patient about. You need to say, well, you've got nasal polyposis and a deviated septum. You probably need your nose open for daytime symptoms anyway, and to facilitate treatment for an inflammatory condition with sprays and things in the long term. The possibilities with respect to your sleep disordered breathing are that the nasal surgery, when combined with weight loss, might be adequate to treat you, and then we surveil you in the long term. Or the nasal surgery might be adequate to facilitate treatment with CPAP or a jaw splint. Or it's quite possible that the nasal treatment doesn't actually improve your facilitation of the device use, in which case we're then looking at other treatment options. And the ranges or the subdivisions within that facilitation are, it might reduce pressure. So you sometimes see patients who are on 20 centimetres of water pressure, which is a hell of a lot of CPAP pressure, where you improve the nose and you can get that down to a significant level, 12 or 14 centimetres, and you might, the tolerance of the device is better. But the improvement might be even more subtle. And some patients, you open the nose and you don't actually improve their CPAP pressure, but you do still improve their ability to wear the device anyway.
I think there could not have been a better description for this thing. We come to the next case. This is a 35-year-old male. BMI is normal, 24, a very low AHI, nose is clear, On the mirror in the dais, it's only an anterior posterior palate. You can see the. So, what treatment should be offered to this patient?
Have you done a jaw thrust manoeuvre, even though it's primary palate AP? Have you done a jaw thrust manoeuvre with the sleep endoscopy?
Yes, Mark.
S-March or?
S-March. No, not in this patient.
Because there are some patients that get coupling when they wear a jaw splint or do a jaw thrust. You can wear a mandibular advancement splint and actually improves the retroplatal airway collapse.
So between CPAP and surgery, what should we advise to this patient?
You take it through that.
I think it's very important that we explain both to the patient very clearly and make sure that they understand that both the treatments available, and also tell them about the success rates. It's also very important that we do that. And once that is done, let him choose,
so
because
low AHI, low BMI patient.
Correct. So
and
that's why surgery could be very well successful for this patient.
Surgery could
but
be very well
at the same time, we should tell the patient that, well, look, if
he
you
has
don't want
to
to have an
CPAP,
option to go for CPAP, if you want to do that, you're more than welcome to.
But you will be confident about operating this patient.
I will tell them that it's a good case, you'll get better success rate.
Correct.
It's also important to note that it's not just the AHI of 10. We want to know whether he's a supine, prone or lateral sleeper, and we want to know on the sleep study what the supine and lateral data demonstrated, because it could be all supine and a lateral sleeping device could help this patient a lot. You can discuss the option of a mandibular advancement splint, but you could say my concerns are there doesn't seem to be a lot of retrolingual issue. It seems to be AP retroplatal, and then there might not be as successful. And you can discuss within the option of CPAP if there's excessive symptoms and the patient wants treatment. There's no harm in a trial of CPAP. And then you can talk about surgical options, both minimal and more significant surgical options to treat the patient if they want to go down that route. It's probably worth noting, depending upon the other parameters on the sleep study, to tell the patient that there's probably no good evidence to say that they're at significant long-term risk from this, what they have. It's just a matter of quality of life, whether they want this treated or not.
So we have another patient who is 50-year-old male. You can see the BMI is pretty high, 35. AHI is 30, nose is clear. And he has got a single level palate. You can see the large tonsils over there. And it's maybe anterior posterior, but only the tonsils are coming laterally. There is no big salpingo-fundal fold. Brainstem is not pressing really. So what is the treatment that should be advised to this patient? Srinivas?
Yeah. Again, I would stick to the formalities.
Stick to the formality, okay.
Yes, I would definitely give them.
No, or is it a formality, or with the BMI 35 will
exactly like I said.
Like him to be on the CPAP for some time and
treat both simultaneously. Is basically what I'm
trying
to say.
CPAP?
No.
CPAP and weight loss.
CPAP and weight loss.
CPAP and weight loss.
Yeah, because you can't give him the time with a dreaded disease with AHI yet. He's now severe apnea. So you have to treat both of them simultaneously and then deal with the situation as it comes back. If he comes back with issues with that, we take care of them. But the first advice I think should be weight loss plus treat the ongoing condition.
It's interesting to note that even with as the BMI gets up to that level, the predictors of surgery are more difficult, but I would suggest that the first salvage surgery option for this patient might be tonsillectomy and modified UPP with a little bit of radiofrequency or coblation to the tongue as a first salvage option, but you would have to tell the patient in the context of their BMI the predictability is less, and so ideally they will most certainly have trialled CPAP and surgery would be reserved as salvage, and ideally they would have lost weight if they can't tolerate CPAP. The outcome from surgery might be better if you can get the BMI down a bit first.
So that was the message. In the earlier patient, because the BMI was only 24, then we were pretty confident about the surgical success. Though we stick to the formality of offering a CPAP. In this case, since the BMI is high, so we'll want him to be on CPAP and weight reduction and use surgery as a salvage.
Well, it's interesting in that his anatomy, despite unfortunately the sleep apnea and the BMI is worse, but actually the upper aerodigestive tract anatomy is more favourable than the other patient. But it still must be said that he needs to try. He needs to be.
That's a very, very important key point. His anatomy is favourable. That we have to understand. We'll come to that part again. So this patient, if you offer a surgery, will you offer him a palatal surgery or bariatric surgery?
I would offer both.
Palatal surgery, because the anatomy is...
I would offer both. I would offer both options. I would discuss both options with the patient.
First palatal, first bariatric.
Well, I'd discuss it with the patient. I would explain the potential outcomes of both. I'd explain that if they haven't lost weight and they've failed with CPAP, it is harder to predict the outcome, although the anatomy is favourable.
If he asks you to take a decision for him?
Well, I wouldn't tell the patient what to do,
Okay.
but I would tell them the options, and I would tell them the potential outcomes, and I'd explain to the patient, if I was going to do palatal surgery, that there's a potential need either for further staged intervention or definitely bariatric surgery. So they may both need to be done.
Go back and play the video once again.
Okay, one sec. Sorry.
I mean, we're doing this just off the nasendoscopy. We're presuming some other
Indian
features.
perspective, doctors are supposed to be trained philosopher and guide.
Yeah.
Srinivas, sir.
Yep.
You offer a bariatric surgery or a palatal surgery if CPAP trial has failed? Or you will not offer a CPAP trial for long? What will be your high BMI, high AHI?
Did he have size 3 tonsils and a low-sitting tongue on transoral examination?
Sorry, come again?
He has small tongue and size 3 tonsils on transoral examination?
Yes. Favorable anatomy.
See, we'd be tempted to really do a surgery for this.
Palatal surgery.
I would offer him an operation, but you have to be cautious and you have to make sure.
Exactly. Again, put it across to the patient, because you're saying about the Indian perspective. Similarly, the Indian mentality is also to flip 180 degrees.
Srinivas, if the patient is your younger brother, you have to take a decision for him.
If it's his younger brother, he would say to him, there are 2 good remaining treatment options after you fail with CPAP, and this is they. And we can only assess each one as we do it, right? And you can explain to him what he has to go through to have both of them performed and what the potential outcomes are. This is an interesting case because I've just had a guy who's about 10 years younger than this, who's almost identical to this description, who had an AHI of 102, and I did a tonsillectomy, modified neutral PNK ablation channeling, and his AHI was 5 at the end of it. But and you know, it's interesting because we don't normally associate BMI of 35 with that type of surgical outcome, nor should we. But you can get isolated incidents where there's definite collapse demonstrable that you can help with. You know, I'd be telling him we're shooting for improvement, not for cure, and that it's a reasonable intervention to do, and that we'll work on the next stage if he has residual disease or residual symptoms from there.
Okay. So we come to case number 4. This is a 57-year-old male. He's a doctor himself. BMI 33, AHI 69. Nose is clear. Mueller and eyes, only palatal, no base tongue, and along with circumopharyngeal fold.
I think the first line of treatment would be a CPAP.
Correct.
And then see how it goes, and weight reduction.
Okay.
Agreed.
He is not CPAP compliant. I'll play the video again. He is not CPAP compliant.
And why?
For 3 to 6 months, he is a doctor himself. He knows everything about it. He has read the internet. He has met all the sleep specialists in the city. Now.
And weight loss?
Sorry?
And weight loss? He's been able to lose some weight or not?
Everything. He is a doctor himself. They are MBBS couple.
Doesn't change his treatment though.
Yeah.
So,
I think, are there any comorbidities?
no, he is not diabetic, hypertensive.
No comorbidities.
And I mean, he's presumably pretty sick, this guy, with that AHI. Yeah.
69 AHI and
Yeah.
only single level obstruction, you can see here.
And-
there is no tongue base. It was confirmed by apnea graph also.
And I mean, the first thing to say is I'm not saying that you're wrong here, Vickers, but I'm always dubious about someone who says there's only single level collapse with that extent of disease. You've always got to consider, is there some other contributor, even though that might be the major contributing factor, you've always got to consider the possibility of another issue at another level. But, you know, if we're CPAP non-compliant and we haven't managed to lose weight, then we're down to mandibular advancement surgery or EPAP or Provent. The treatment effect from Provent, as far as we know, is a modest improvement, and it's probably not going to get you there with this guy. And probably the same can be said for mandibular advancement splint, although there's certainly isolated incidents of improvement, usually not in patients with such a degree of palatal collapse. So probably you're going to be discussing...
Sorry.
You're probably going to be discussing contemporary surgical options with this patient, staged approach, and looking for improvement rather than cure.
Correct. Yeah. Please.
I will say breathing exercises.
Okay, sir. So what we'll do is we'll take the comments in the end, because there's enough material to come.
We'll take the comment. Well, I think we're going to take that comment while it's here now. There's absolutely no good evidence to support conscious breathing techniques for an unconscious condition. That's a very important thing to note. There is no good high-level evidence to support Buteyko method or other methods for treatment of obstructive sleep apnea. I don't have a problem with use of adjuvant treatment for weight loss if it helps. There is some low-level evidence to support those things that strengthen upper airway musculature. There's some South American randomised evidence with a very mild or modest reduction in apnea-hypopnea indices from speech therapy. And there's some lower-level Australian evidence supporting didgeridoo use and presumably trumpet players and things for strengthening musculature. But it does just that, strengthens musculature, so it's only going to be a minimal improvement. But there isn't any good evidence to support breathing techniques for what is a non-conscious condition. We're in sleep when it happens.
Thank you.
So you think he stops breathing at all in the night?
No, not at all. Now the apnea is gone completely.
It's not gone completely, it's 11. So that are mainly hypopnea.
And the snoring has reduced?
Snoring has reduced to quite some extent. And sometimes even he's not snoring at all. He's in deep sleep, he doesn't snore at all.
So the message is not that this patient did very well. The message is that generally high AHI is associated with a multi-level collapse and not so good results. But it does not mean that in every case you will get a multi-level obstruction with a high AHI. You can get a high AHI with a single level of obstruction. And it does not always mean that your surgery is going to fail. That's the general understanding. We have to go by that. So we have to be very, very cautious. But if your assessment is absolutely perfect, then in a given case, that's not always true.
Because you're saying that doesn't mean this is a good result. I would say it is a good result. I think that's a very good outcome to get to at this point in time for someone who had such significant disease and was unable to wear CPAP.
This was after 6 months, and the patient couple are doctors.
That's a very good result. You need to surveil him in the long term. If he's not complaining of significant symptoms,
2 years post-surgery.
If he's not significantly symptomatic, then you'd probably try and follow him up at 12 months and 3 years. And if there's significant weight gain or recrudescence of symptoms, investigate him again. But that's a pretty good early outcome. I think you're selling yourself short.
Yeah. But you cannot expect this kind of
exactly.
result in every patient.
That's the point I'm trying to make.
No.
Don't take it as a generalization.
No.
These are...
Don't just jump on operate on...
Yeah, exactly.
No, we'll take the questions. There's another case, 37-year-old male, only 37-year-old. BMI again similar, 33. AHI only 28. And you see, base tongue, palate, both. I am showing the base tongue part and the epiglottis. This is my favorite video. And significant desaturation, but patient is able to breathe, so his AHI is less. Okay. Panelists, treatment. You think CPAP is going to seen during Miller's maneuver. So drug-induced sleep endoscopy, when I started doing 2.5, 3 years back, then I started realizing that during Miller's I was missing the epiglottic fall, and these patients at me from this angle is good but not sufficient. How much time do we have? 23 minutes, okay. So looking into the anatomy from this side is generally not sufficient, because if you see this guy, 36 BMI, AHI 28, Srinivas, what is your take on the Friedman tongue position?
Yeah, I think it's 2B.
Or 3?
Tongue
3
is
or
out,
4?
yeah. Tongue is out.
It's going to be a big tongue, I think.
Yeah,
Yeah,
it's a
tongue
big
is
tongue,
out,
yeah.
first of all.
But if you see this guy in the operating room at the drug-induced sleep endoscopy, and when we are seeing it from inside, the base tongue is not falling, is not obstructing, So definitely Malampatti and Friedman classification are good to indicate the difficulty in intubation, but it was a very good predictor for the role of base tongue, but we cannot take it blindly, because you have to examine the whole airway from the back with a flexible endoscope.
Just as we can't take the dice blindly as well.
Sorry?
We can't take the dice blindly as well.
Agreed, agreed.
That's correct. You cannot.
Agreed.
So the message still here was that surgical success is definitely multifactorial, but the single most important factor is the anatomy causing obstruction. Do we all agree with that? BMI is not the most important?
No,
AHI is
not really.
I'd end the sentence after the first 4 words, probably.
Yeah. Anatomy is not the only factor. There is, because we should understand that obstructive sleep apnea syndrome is a syndromic disease. There is an anatomical factor to it.
So
but
I'm telling about surgical success.
Exactly.
Because what surgery will plan will not depend only on BMI, AHI. Anatomy will play a major role in, because you are cutting that anatomy.
Ultimately, when you're talking about outcome, because anatomy is not the only factor, because there are other issues.
Single most important factor for your surgical decision.
I don't think we have evidence to say it's the single most important factor. Anatomy is a major factor in deciding on
which procedure you would like to pick up.
Yep.
But end result,
So obviously you go by the protocol.
End result, ultimately it comes down to airway dynamics, and the predictability is very difficult. We do the best we can with every tool we've got at our disposal.
Okay, with anatomy, when I was in China last year,
I can't read that, Vickers. Can you tell us what that says?
If you can see the guy standing besides me, he's got retrognathia. The translator has got retrognathia. Do we all believe that the structure of the face, our faces are somewhere different, the Caucasian faces are different, and the Chinese faces are absolutely, they are two different ends.
Absolutely.
So does that really play a major role in the difference of recommendations that we can have in our, because we do not have data, so much data in our Indian scenario. China, tongue base is the biggest problem, palate is not the big problem, tongue base is the biggest problem.
I think it's...
There's guys like Peter to help you build the data on what the airway anatomy and physiology is like, and I think Peter's already getting involved, but that's what you need to do for your demographic. There's no, the more information we know, the better. The more information you know about the Indian population and the anatomy and the cephalometry and the soft tissue, that it can only all help.
So the anatomy of the nasopharynx is not only dependent on what you see from there. Even the face structure, like we have just seen, is important. So if there is a single level of obstruction, there is no confusion. But what we do if a person has a multi-level obstruction? We have very small time left, so we have to be little fast. Now this is a multi-level case, nasopharynx, nose, palate and base tongue, all. Sorry. So what do we do if the base tongue, nasopharynx,
is that that's adenoid hypertrophy there, is it? And what are the features in the nose? Have they got a deviated septum or turbinate hypertrophy?
Correct. And the base tongue also. If it is a multi-level case, then how should we approach it? Do we do this surgery in a single sitting or staged?
Very quickly, presuming they've got sleep apnea, trial of CPAP. If CPAP doesn't work, pre-phase nasal surgery with turbinate reduction, adenoidectomy, septal treatment. Repeat the trial of CPAP. If there's a failure of CPAP again, despite the repeat
we have done
trial.
that, Stuart, we have done that. A surgery, will we do it in single stage or multi-stage? We'll stage it.
Well, that can be discussed with the patient as well. So but definitely the nasal surgery, personally, I would stage, and that's for. So that's
because we are running short of time, we have to be a little fast.
Can I have the history of the patient, what you have given?
Sir, it's a multi-level case. It has failed CPAP trial and he is for surgery. So nose and palate and tongue.
What
is
the AHI?
So it's a high AHI.
See,
high
again, AHI plays a very important role. We need to categorize whether this patient is a mild case, a moderate case, or a severe case.
He's talking about significant sleep apnea.
Severe case.
If it's a severe case, there's a huge adenoid over there. If you're going to put a CPAP, that's going to come in the way.
No, and if CPAP has failed, we have to do surgery. My question is whether we do in single stage, all the 3 levels, nose, palate and base.
No, you would do the nose first and then retry CPAP. So even if CPAP has failed, you would fix the nose first and repeat the trial of CPAP.
Perfect. Your answer is you fix the nose first and again give a CPAP trial, and then if he fails that, then go for the throat. Correct. Srinivas.
Yeah.
Single stage or multi-stage?
For me, I mean, I would do it as a single stage procedure, discuss it with the patient.
I'll ask you things later.
Single stage, nose and palate, 2 major procedures, 1 minor procedure which is on the tongue, which is RF application to tongue base, all in one sitting. Along with it, the adenoid removal.
Perfectly, all right. So, if you are doing it in a single stage or different stage, how to anticipate difficulty in intubation in a multi-level case? You use DICE for that anticipation, and what is the preparation, sir? Dr. Vinay, sir, will you like to say about the anesthesia preparations, intubation?
Yeah, a good clinical examination and OP endoscopy will give us an idea.
Correct.
Whether it's going to give us any problems during anesthesia. So most of the problems which can be anticipated can be diagnosed in this way.
Dr. Dindal?
Normally, we don't do any DICE at our place. We do only Muller's maneuver. And once we have a look at the whole thing, we get a clear-cut idea whether there would be a problem in intubation. Our anesthetist also has a look at it. And invariably, he'll have everything kept aside, ready to manage the thing. And we haven't truly faced a problem once we plan out what is the problem that's going to be there and how you are going to tackle it.
Okay, Srinivas.
Yeah,
so
I think
if you're doing 3 major surgeries in single stage in a high HI patient, so obviously the anesthesia consideration is very, very important. I want you to elaborate on that.
Yeah, basically you get the anesthesia, pre-anesthesia checkup way in advance, get the entire workup, the metabolic
quality
workup.
Of the anesthetist. Quality of the anesthetist and his understanding of this subject.
Absolutely. I mean, for somebody who you really trust, I mean, who you've been working with, that's very important. And
never work with a new anesthetist, howsoever senior he is.
And I would say not a single person, normally a team or at least 2-3 people should be there because these are syndromic patients. And number 2, even for us, the moment he walks in, all OSA patients are, like yesterday Dr. Jagannath was saying, are difficult patients to intubate. None of them will be a simple ASA grade 1 case. All of them, all these OSA patients are packages. We need to take the entire package with their metabolic issues as well and be ready with whatever comes at you.
The message is that you may be very, very good in your surgery. You will do all the 3 levels beautifully in one stage. The anesthesia backup, the anesthetist, his understanding of which case is difficult intubation, his preparation of this true view laryngoscope which is 45 degrees, very, very important. Because if it is a big tongue base, with a regular laryngoscope, the anesthetist will not be able to see anything the moment he induces. The whole tongue base will fall. And then he has to understand that with true view it is easy. Sometimes you have to do a fiber optic awake intubation. Awake blind intubation you have to do. So that the anesthetist has to understand. And if you cannot intubate the patient, it is a must. My understanding, the panelists can support or disagree, that LMA has to be ready for rescue. At least if you cannot intubate well, put a LMA
or a nasopharyngeal airway.
Or a nasopharyngeal. Sometimes the nasopharyngeal airway is also not enough for the huge base tongue. If you put a LMA, at least it will keep the base tongue high and the patient will not collapse. Anybody wants to add anything in that? Okay, so we have intubated the patient. We have done a single stage or a stage surgery. I personally believe that a stage surgery is good. Stuart is of the opinion is that you should do the nose first, give a CPAP trial again, and then if he fails, you should do a second stage oropharynx. Srinivas is of the opinion that you can tackle all the 3 stages together. Dr. Deendayal is of the opinion that you can do 2 major, that means nose and the palate together, followed by the base tongue in the next setting. So there is definitely no agreement on what one will do in one setting. So please do not carry home any message from anybody. You all are learned people. Do not blindly follow Vikas Agrawal, Stuart, Srinivas or Dr. Deendayal. You see the patient, have that understanding to what your conscience allows you and you are comfortable doing. It's your patient. If he is in trouble, you cannot quote me, him or anybody or the literature.
There's one important point that I'd ask Srinivas and the other panel members. If you have 100 patients like this patient lined up, 100 exactly the same, and they've failed with CPAP, what percentage of that 100, how many of that 100 will wear CPAP again after you do the adenoidectomy and turbinate reduction and septoplasty?
Well, there's a good chance. I mean,
then you're operating on them for nothing at the palate
exactly.
and tongue level. So they really should have pre-phase nasal surgery.
No, that's what. So we're selecting the case selection in the initial phase itself. You have to rule all those out. I mean, give them sprays, give them all the conservative things. You're coming to surgery only after you've tried all the conservative ways possible.
But you haven't operated on the nose yet. You haven't done the nose yet.
Correct. If there is a significant obstruction in the nose, yes, I would definitely go with what you said. Yes, stage it.
Fine. So you have done a multi-level surgery. Will you extubate the patient immediately on table? Will you keep the patient in ICU with nasal intubation for 24 hours? Or will you do a tracheostomy? For myself, hold on. Stuart,
it depends on the extent of the tongue reduction.
No, I'm talking of multi-level. That means it is a tongue-based case. I'm not talking of simple palate.
It depends on the extent of the tongue reduction.
Extent of the tongue-based reduction. Perfectly all right. So if we are doing a multi-level surgery with a significant tongue-based procedure, not only channeling, if you are removing a significant amount of tongue-based, my protocol is that I keep the patient in ICU with nasal intubation for 24 hours for the understanding that the patient has a time to come out of anesthesia completely. It's obstructive sleep apnea. So once he's out of the sleep, his obstruction will not be a problem. Second, if there is any bleeding, primary bleeding I can check on table. Reactionary bleeding can happen up to 24 hours generally, most of the time. 4 to 6 hours is the commonest time of bleeding, and up to 24 hours person can have reactionary bleeding anywhere in the body. Secondary bleeding will usually happen within 5 to 7 days. So I take that chance of reducing, I take that opportunity to reducing the chance of reactionary bleeding, and so I keep the patient in ICU with nasal intubation for 24 hours. This is my protocol. Let the panelists say what they feel.
That's for a significant tongue reduction, that's a safe approach.
Thank you. Srinivas.
Yeah. Well, as you correctly pointed out, the duration. If you take adequate precautions right from before the surgery, start prepping them, give them steroids, give them, keep the CPAP ready, make arrangements for, if you take adequate precautions, yes, it's very important to keep them in the high dependency critical care unit, but you can extubate them on table, and that was my paper in the World Congress.
Dr. Deendayal.
You want to talk about my experience? The multi-level surgeries which we normally do is 2 majors and 1 minor. When we are talking of 2 majors, most of the time it will be complete nose work, adenoid, and the palate work, followed by radio frequency application to the tongue base. Case selection is the most important thing. If the case selection is perfect and there is no major surgery done on the tongue base, all my cases, there is not even one single case that was not extubated in the operation theater. These patients are shifted after extubation to the SICU to be followed up. If in case there is an issue, they would be managed. But all cases are extubated on the operation table.
Dr. Vinay Kumar would like to
In my experience, multi-level surgery I would keep in the ICU for 24 hours. And before intubation, make sure that the patient is off any sort of sedation or so that is fully awake, and then we extubate.
Yes. Perfect. Stuart, you were saying something?
I think there's two things to note. The series with the biggest reports of aggressive tongue reduction, so if you're taking a submucosal laryngoplasty, for example, demonstrate that there is a risk.
Correct, correct. Suppose if you have not done, there's a big tongue base and you have not done a big surgery on that also.
If I've done midline glycectomy and lateral channeling, I'll extubate the patient. But if I've done some lateral dissection or a very aggressive tongue resection, then I'll keep the patient intubated.
So what is your take? If it is a big tongue base which is likely to fall immediately post-surgery,
then
you have not operated it also. You have not made it small.
You haven't operated on the tongue. No, then you could potentially extubate that patient, but monitor them closely. So
monitor them closely.
Yeah, they'll be monitored. There's another point to make is about if you are going to do concurrent nasal surgery and palatal work, I think you still probably shouldn't do concurrent adenoidectomy and palatal work because the risk of VPI is still greater.
Okay, so we have done a multi-level surgery. Now we have done the nose, palate and tongue all together and we have packed the nose. If you have done a surgery, septoplasty, turbinate, fez, adenoid, do you pack them? Most of the people will pack up the nose. So if the nose is packed, the mouth has to remain open. If the mouth is open, the mandible goes down, the hyoid goes behind. In this position, the hyoid is at the back, which makes the tongue base fall further. This is like a situation, domino effect. You push on one bicycle, all the bicycles will fall. So the patient's airway is furthermore compromised. So
you get good packs with airways nowadays.
Will you pack the nose after multi-level surgery?
I don't.
You don't? Perfectly all right. So if you do not pack the nose, then there is no problem, sir.
I do pack the nose.
So have you ever faced this kind of a situation that because of a big tongue base and packing the nose?
That is what I specifically said, case selection. You need to assess your tongue. If you know that your tongue is going to be the problem, don't ever do that. Then I will not even extubate the patient for the next 24 hours. But most of our patients, when we select, and even after the nose is being packed, the patients do pretty well. But the answer to that is, previously there was redundant palate, and you have widened the palatal area. And when you do that particular procedure, the anteroposterior, the lateral and the superior-inferior space gets widened. There is invariably some amount of air going retrolingually. So we have never faced that issue.
We had 3 patients in the last 5-7 years in Bombay. Patient died after septoplasty. Just observe in the observation room, after 5 minutes the nurse came, the patient died. So it was a undiagnosed OSA case. After septoplasty, the nose was packed, the patient was...
That requires a lot of debate. There could be many issues. Has the patient been reversed? Has the patient been sedated? Does the patient have any other illness that hasn't been looked into?
Sir, I am coming to that because this patient was only
so you
septoplasty.
can't just say that.
They never thought it was OSA and they gave them good sedation.
Say that.
Pretty good sedation
for
local anesthesia plus strong sedation for septoplasty. So OSA patient, if you anticipate that the tongue is a problem, packing the nose should be careful. I'll come to what if you're not packing the nose, Srinivas, what do you do if the nose bleeds?
Since the patient,
you'll have to pack the nose at that point of time.
Again, make sure that you've achieved good hemostasis. Make sure that the pressures do come back after surgery. Then even after that, yes, it could still bleed.
It can still bleed.
Because the patient is in the ICU, you just have to take the patient back.
So by the time it will bleed, patient will generally come out of anesthesia, and then you can pack the nose. But this is one thing that you have to keep in mind. That's what. What if the palate bleeds and what if the tongue bleeds? Well, you think it will be easy to re-intubate this patient who was a difficult intubation in a bleeding state, and the patient doing like this when he is not completely out of anesthesia?
Well, he would be a little better than what you have done before the surgery. No, there's not so much of overcrowding there.
If the nose is packed. You don't pack, so Stuart, you would like to comment on this situation?
I don't pack and I don't do multi-level surgery that involves bone and cartilage work to the nose at the same time. My palates don't bleed, but tonsil fossa do. You mean tonsillar bleed? Because I don't do any procedures that will allow the palate to bleed. the bottom one there, if the tongue base bleeds, that is important, and that is an emergency, or should be at least dealt with as an emergency to secure the airway.
Correct.
And that airway securement may require an awake fibre optic intubation or trachea.
Correct. And let me tell you, tracheostomy is not easy in these patients who are not getting oxygen. They're moving like this. You'll not be able to do a tracheostomy in time.
I will say this is just to reiterate what I said in the session, that if you're doing tongue-based work that is aggressive or substantial, then you should try to, I mean, we hate to say aggressive or radical, but if it's extensive, then you should try to monitor the blood pressure closely, and I would suggest arterial line monitoring and maintaining mean arterial blood pressures always below 100. So that they never get up below that level, above that level. Just the point that Srinivas was saying about getting good hemostasis in the nose on table, the same applies for the tongue. And if I'm doing a midline glossectomy approach to remove portions of the tongue, then at the end of the operation, I'll ask the anaesthetist to alter the parameters to allow the map to climb up over 100 to assess for bleeders prior to completing the case. So it's a bit like you would, along the same lines, you do a Valsalva in the neck.
So I think the message is that before venturing into multi-level surgeries, it's not as simple as just taking up any coabulator or plasma, radio frequency or laser and start cutting things. You have to understand the physiology of these patients in much more greater detail, and your preparation of the HDU has to be done, your anesthetist has to be done. I'll skip on what instrument to use and what angles of endoscopes to use. Dr. Vijay is not here. Any comments on the, so if you do not want all those complications of the airway, will you like to comment on the hyoid advancement?
Sorry?
If you do not want a problem with the base tongue surgery, bleeding and all, this is a much safer approach, hyoid advancement. Anybody wants to comment on that?
Yeah, I decide to do hyoid advancement depending on the cine MRI studies, which will show us exactly what type of tongue base obstruction it is. And I found doing this, there's no post-operative obstruction or any breathing problems.
So you think, and you think it's a very efficient procedure, it's effective?
Yeah, usually I do multi-level obstruction at the same time.
Correct.
So I find it a useful and very simple procedure.
That's a very, very important message. If you want to do everything in one sitting, nose, palate, then at least you can, you may not do the base tongue, palate, you may do the nose, and you can do the hyoid advancement. It's from outside. So it's definitely not going to compromise your airway. A lot of issues on when to do soft tissue surgeries or bony surgeries. Genioglossus advancement you saw day before yesterday. MMA, maxillomandibular advancement, is supposed to be the answer for all kinds of sleep apneas, because you increase the size of the box in which the soft tissues are fitting, but it's definitely a bigger surgery, and as the rules of the game are becoming more and more clearer and the surgical expertise is increasing, possibly the morbidity associated with this MMA will also come down, and this will be a very, very significant approach. A lot of learning is going on and is required before we graduate to say that we can give results in the surgery of OSA. A lot of cadaver dissection courses by all of us are coming down. This is my email address if somebody wants to write to me, dr@enthospital.com, you can remember that. And thank you all for being here. 1 cheers for the organizing team, 2 cheers for the panelists, and 3 cheers for the audience. Thank you. Yeah, we had finished on time, dot on time, so we can take some questions.
We had wonderful panel discussion.
Yes, Dr. Suryaran.
One of your slides has clearly mentioned that most of these situations the patient is extubated awake. So in these circumstances there is hardly any chance for giving any narcotic analgesia. Other thing is, if there is any potential risk like that, which you mentioned, even in major head neck surgery where the tongue is removed and the mandible is removed, we leave the endotracheal tube for 24 hours.
There is no harm in doing so.
So if you have any such doubt about it, probably the better option is to leave the tube, and mostly the patients do tolerate the tube for 24 hours. About nasal packing, mostly the surgeon at the end of the operation knows what has been done and what is likely to bleed after he is removed from the theatre. So depending on that, you need not give a pack. Many times you can get away without giving a pack. This is what I feel.
You are absolutely right. For myself, sir, I hardly pack 2% of my noses. I put a silicone splint, but OSA patients are different, and what I do in my practice is not important. Most of the people, I would take a hand raise. How many people leave the nose unpacked after routine septoplasty? 1, 2, 3, 4. Rest of them pack the nose. So that's what most of the people actually pack the nose after septoplasty and turbinate surgery. So that's the reason I put up that.
The first point is well taken though. If you are in any doubt at all, err on the side of a higher level of monitoring than a lower level of monitoring. So if you think of this patient needs HDU, then put them in HDU. Don't put them in a lower level of care. If you think this patient probably needs intubation for 4 hours or 12 hours or 24 hours, then leave them intubated for that period of time.
I'll call you. I'll mail you.
There's that case number 4, Vikas, that you showed. I think that was only palate, high BMI and high AHI. Okay, my question to the panel: wouldn't you think that the doctor couple that you mentioned? Wouldn't you think that would have been an ideal situation to do an RF under local, at least for the palate? It was only palate.
High HI, 169.
Under local palate, RF palate under local. Along with the what the panel said. They said we'll start a CPAP, retitrate after 6 months. But that I would say that would have been a good option.
What are you doing the RF for?
He said it's a palatal obstruction. We're trying to shrink, volumetrically reduce.
To treat apnea?
Just try to open interim period while you're doing what you're doing with the CPAP. You're doing with the RF. You're trying to, in the interim period, you're going to try and open the anteroposterior airway.
I think you're not going to make much difference to that guy.
I agree. I mean, it's just an attempt that you can do under local, which is very safe.
Yeah. Dr. Bilgi.
Namaskar. I do a lot of pediatric obstructive airway things and all. I always find one pathology, a primary, and secondary to that there are second multi-level sort of thing. So once I address primary, the secondary disappears. So is it rational on the part of you to address all at a time and give him a more morbid post-operative period than are there any effort ki one of them is a major driving force and others fall to that? You understand what I mean?
Personally, I 100% support you, and that's why I do stage procedure. Vidya Sagar has a study to prove that if you do the nose, the lower part actually worsens. I am not able to understand that study, but that study has come from a very respected center.
I think in adult obstructive sleep apnea, it's rare for there to be a single driving event, but there are cases where there's a single driving event causing collapse at more than one level.
Right.
So that does actually happen, but it's probably different to the pediatric population in that regard. There's often multiple levels of different causes of obstruction at those different levels, unfortunately. Otherwise, we'd probably do a lot better than what we do.
Well, but if it's a syndromic patient, if it's a syndromic patient, if it's a syndromic child, then the ball game is completely different.
Syndromic children is a different story.
Understandable. That's understandable. Thank you.
So if there's no other question, yeah, Dr. Ravi.
So what is the role of salpingo-pharyngeal folds in the obstructive scenario, and how to address the whole situation?
The salpingo, this question let me answer, because this was first described by me in the World Congress last year. As you saw in that case, that doctor's case, it's not only the anteroposterior diameter of the palate, it's the lateral diameter also. And the lateral diameter in the lower part, which is formed by the palatopharyngeus, can be tackled by expansion pharyngoplasty as popularized by the Woodson and the Kenny Pang group. But the higher part, as you just saw, they are very significant folds, and they are seen in almost 70% of the patients. And you have told me, after I told you, you told me that you are seeing a lot of salpingopharyngeal folds. Srinivas told me that as he started looking bulky edematous salpingopharyngeal folds. So even if you do expansion and a proper UPPP, still the patient does not improve. So what I have presented is that I do with the ultra SP wand from coblation, I do a channeling of these salpingopharyngeal folds where they are going to meet in the velum and they shrink. That opens the airway to a certain extent. Definitely there can be better ways of doing it. Possibly we'll come down to that.
With no disrespect to Vickers's work, which is excellent, I think the general sleep community and the broader scientific literature, it's an unclarified role of the salpingopharyngeal fold. Needs more investigation.
It needs more investigation. So we thank you all for being here in the pre-lunch session, and we once again thank the panelists.
Dr. Stewart, question for you. What is your experience on patients with combined OSA and insomnia? Do you treat the insomnia separately, or does surgery improve the insomnia? This question is by Dr. Ranjini.
It's an all too important question, the amount of patients that have more than just one sleep disorder. So they have a sleep-related breathing disorder and also have another one. Generally speaking, in my practice, they're managed in a multidisciplinary clinic. So I run a multidisciplinary clinic where we bring complicated patients and they're seen simultaneously by all the clinicians. So sleep physician, surgeon, sleep psychologist, weight loss expert, dentist, and so forth, all in the one clinic. Really what you need to define is what's troubling the patient the most as to what treatment modality you go down first and what their risk is from their sleep apnea. So if they've got significant risk from their sleep apnea and significant symptoms from their sleep apnea, then you treat the sleep apnea. If they've got significant symptoms related to their insomnia, then you treat the insomnia. But it would be fairly uncommon, and you shouldn't draw a bow to be able to say that my surgery or my intervention in the sleep apnea is going to resolve, cure, or have significant impact on the insomnia. So I think, you know, there's a blurred line between some of those things where other conditions exist rather than insomnia, where you may get some improvement in other disorders in sleep, but not truly insomnia. I can't provide any evidence that would say that.
Thank you, Dr. Stewart. Srinivas, you are extremely popular. There are about 8 questions for you, but I think I'll choose one of this, which is related to DICE versus sleep MRI.
Correct. I think that's a whole debate. In fact, whoever attended a workshop in December, we had a debate wherein we actually, each one of us actually debated for and against. Like I said, they're mutually, the different things. I mean, if you're hungry, you can eat oranges and be happy about it, or you can eat apples. It's basically what is making you get the information that you want to treat your patient. If sleep MRI works for you, that's great. I'm not saying DICE is better or sleep MRI is better. All I'm saying is each one of them are good. See which works for you in your hands and just try to do that. The home message is, you see, I mean, that's what, the sleep MRI, talk is not done yet. So listen to that also, and then probably we can have a debate. That is not multiple factors. It's not just DICE, that if you have a flexible scope and your radiologist says, no, I want to go home after 9 o'clock, you can't do MRIs after 9 o'clock, after the patient comes home, after eating his food. No. There are different people who do modified Mullers and do a cine MRI, which I don't think is that, I don't think. Well, there are other things. Dr. Woodson actually advocates what is called as end expiratory phase, which is, according to him, he believes that's the narrowest, that's the point, how do I put this across? It's according to him, That's the lowest diameter. At the end of expiration, in a patient of obstructive sleep apnea, at the end of expiration, that is the place and that is the time where the airway is at its narrowest. So he believes in that. So different people.
Can we go to the next question?
Sure.
Peter Eastwood, doctor. I'll read it out. It's very long question. Wonderful technique. Could we place a lens fiber optic at the tip of to simultaneously see the area which we are measuring? As the surgeon, this would be benefiting to address the area properly. I think what he means is, could you add a gadget by putting a lens at the end of it, so that concurrently you can see what's going on?
Yep. I don't think that you could put both the imaging lens and the optical coherence tomography probe in the same system, but it's small enough that you could quite comfortably put a separate nasoendoscopic probe down and lie right next to it, so that's not a problem at all.
This is the last question for Dr. Vikas. It is from Dr. Deepankar Datta from Kolkata. 38-year-old male patient, AHI 4, BMI 25, saturation 94, and something central apnea, mild DNS. What to do next? Is DICE justified? Vikas, can you give a brief
I really did not follow. Yeah, Deepankar, normal BMI, AHI 4 is normal, okay. Okay. 95 saturation, okay. 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 6 central apneas in 6 hours of study? Nothing is to be done. Nothing is to be done. It is a normal study. See, as I told in my talk, if some holds the breath for 10 seconds, it's fine. 95 saturation is all right. BMI is normal, AHI is normal, nothing is to be done. So 6 central apneas is even 1 per hour. That's absolutely perfectly all right. Not really, no. Central apnea or 5 to 6 is absolutely, DICE is not indicated. Thank you.
Thank you, sir. I request the chairman, sir, to give certificate and mementos to our speakers, Dr. Stuart McKay, Dr. Vijay Krishnan, Dr. Srinivas Kishore, Dr. Peter Eastwood, Dr. Vikas Agrawal, and Dr. Rajkumar. Hello, hello.
Sir, please. Yes. Yes, sir, come little forward. Sir, lightly. Okay. Okay. Yes, sir. Ready, please. Yeah, okay. One more, please. Thank you. Thank you.
I request Dr. Jagannath to give a certificate and memento to Dr. Surya Narayana.
Sir, please. Sir, please. Sir, please.
We'll start with the panel discussion after half an hour. So we can have a half an hour lunch break. Sen Murthy. So he's professor and head of the Department of ENT and Head Neck Surgery at Dr. Pinnamani Siddhartha Institute of Medical Sciences and Research Center. He is fellow of New York Academy of Sciences, International College of Surgeons, Royal Society of Medicine, and American College of Surgeons.
Welcome to the post-lunch session. And this is first conference on sleep apnea and surgery. Please don't sleep again after a good lunch. So, not to allow you to sleep, we got a good panel of people coming on to the dais. First, I request Dr. Manoj MP to come on to the dais. Manoj is the director and consultant ENT surgeon at Manoj Super Specialty Hospital, the one and only best ENT hospital in the west coast of India. The largest series of cochlear implantation he has done, and he has got special interest in otology and sleep medicine, presented papers in various international journals. I request Dr. Richard Ellen to come on to the dais. I don't need to introduce him again. He is the Associate Professor of Neurology at the Johns Hopkins University School of Medicine. I request Dr. Venkateshan to come on to the dais, a consultant in Advocate, Illinois Masonic Medical Center. I request Dr. Peter Eastwood to come on to the dais, Senior Research Fellow at the West Australian Sleep Disorders Research Institute, and Dr. Vidyasagar is the Associate Professor of Department of ENT at NRI Medical College in Vijayawada, and the man who is going to run this show, Dr. Seemap. Dr. Seemap is the head of the ENT at Inamdar Multi-Speciality Hospital and sleep consultant at KEM Hospital. He is very much interested in sleep medicine. So I request Seemap to run the show.
Sir, if you can just call Dr. Stuart McKay also. We have one place, so we'll invite him on also.
We request Dr. Stuart McKay also to join this extinguished panel.
This is working. I think in a way that you will all be able to see the screen a bit, but there's really not much that we're going to have to look there. I just have a couple of videos and we're going to try and have a very nice practical discussion on this. Good afternoon, everybody. Welcome back post a very nice meal, and we're going to try and keep the momentum up. A few apologies in the beginning itself to the Professor Allen, Dr. Peter, people not from our fraternity, but you will play a pretty important role in a few of the important questions and the messages that we need to bring out. I have limited set of questions that I think I can direct to y'all, but please bear with us surgeons for the rest of the time, us mere mortal surgeons for the rest of the time. I'll start off on a lighter note. I'm not directing most of my questions to really anybody. I would request all the panelists to feel free, pick up the mic and let's get going. But in case things are going a little beyond hand, I might have to be the bad headmaster and cut somebody off. So my apologies for that in advance. It's unintentional. It's going to be purely for us to maintain time. Who do you think should be treating sleep disordered breathing in OSA? Any one of you can just pick up. Peter, in fact, I would like to ask you, why is it that ENTs were never thought of when this is purely considered so much of a pulmonologist domain?
It's kind of a history, is what you want a history? Yeah. Maybe Richard can give you a history of the US and I'll give you one of Australia.
Well, you have to understand that if you just go back, 30 years, nobody knew about sleep disordered breathing or sleep apnea. And then it was really uncovered originally in Italy and then Stanford in California, where actually There is a secret paper from Hopkins, so since I'm from Hopkins, I'd like to think Hopkins had the first publication on it, but nobody knows that paper and didn't do anything, so we can't give them any credit. But there was a paper on sleep disorder breathing that dates back some. But so nobody knew about the people who studied it initially came out of the group in Italy who were physiologists and neurologists, and then the group that developed at Stanford under Dement, who I said discovered REM sleep. And so the entire development of the field at Stanford then pulled in some pulmonologists to deal with the respiratory issue. And it's so developed historically by that group. And only secondarily did people realize that you could open the airway. And as you know, that came first from a Japanese surgeon.
So in effect, what we're actually thinking of is the fact that it was the laziness of ENT surgeons to get into this? Was it just that?
No, I don't think you're lazy. I think you're very brilliant.
Should we wake them all up post lunch and say, please get up, look at this branch, it's for us?
What I think is really brilliant is you've realized, in fact, I have a paper on some of the imaging of the airway, which I did early on, and you realize that once you look at that airway, you realize that there's surgical potential to correct things. And so this was a finesse of great importance that comes as a second step in the development of the field. And so I think you should see yourself as as adding an important dimension to the field that was totally missing in the early studies, which are mainly, physiology.
So I'll put that to the ENT surgeons. Yeah, please, if you want to say something.
I'll just add to that quickly from the Australian perspective. It's interesting that the growth of sleep medicine in the US has come primarily from neurology, I suspect. In Australia, it's come primarily from the pulmonologists. And in fact, the person who discovered CPAP, still the gold standard treatment of sleep apnea, was Colin Sullivan from the University of Sydney, an Australian. So Australia is deeply rooted in pulmonologists being involved in the treatment of sleep apnea. So that's historically where it's come from. And now, of course, as the complexities of disease have become more and more appreciated, and the challenges of treatment have become more and more appreciated, there is a role for other disciplines. And I think that's the only reason that ENT has not become involved earlier.
I think all us ENTs should start now focusing on this particular branch, right?
I'd like to add to that. In my own practice, we have a system where we understand this is not a one-man show, and we believe in the team approach, multidisciplinary. We feel there may be an element of bias here, but we feel we're at a better position to advise patients about the options, including CPAP and non-CPAP. We have a dentist who works with us on oral appliances and everything under the umbrella.
Very valid point there on that, TV, that this is exactly where the ENT surgeon would probably score over the others if the ENT surgeon takes a little bit effort to understand the whole gamut of the sleep things. We could possibly do a little bit more than CPAP sometimes in those patients who don't really require CPAP.
We also set it up so that patients are aware we are surgical scientists, we are surgeons, but that is not the first thing we do.
Yes.
They understand it is a process. We are with them throughout the process. We will see them through their success as well as failure. We do not promise them cure. We only talk to them about control. The patients nowadays are very comfortable with the idea of a chronic illness such as hypertension or cardiac disease. So
beautiful.
That's
very
the approach
well put,
we tell
I would
them
say,
is
because
we're going to titrate our approach, and sometimes we have to do a little more, sometimes we peel back. But it's a process, and we're in it for the long haul.
We don't cure asthma, we control asthma. Very well put, I would say. That's the right message that we need to get across. Let's skip this one. Now, we've been seeing... Sorry,
Could I just add one comment? I'm impressed with the fact that for pulmonary evaluation of sleep apnea, it's really CPAP, and there's not a lot more in treatment. But what you all are doing is just the beginning of developing how well your treatment will be, and you have a lot more future development and treatment options than I think we do, that I think is available in other disciplines.
So in the morning now we have covered a bit of the symptomatology, over various lectures. We do know that a patient would come to you for snoring with some kind of daytime somnolence, etc., etc. Now tell me, what would you do when a patient is really not come to you for snoring? How would you go about trying to find out if you're suspecting yes, this is an OSA?
Simam, it's a very important point. I think when we treat patients with any disorder, not only this, I think we have to have three things under consideration. One, does he really have the problem? Does he really desire to have it treated? And will the treatment close all of the options of cure? So I think if putting all these things into perspective, if we have somebody who coming to you just because you think that he might be having snoring, I think we are hitting the wrong tone. Like you said, that your previous slide talked about awareness.
Yeah.
We have in our clinic a small poster that says what snoring can do to you. And people come up to
you advise that you keep up some kind of awareness issues at your setup, and if the patient actually comes to you. Yeah. So
I don't think we should be telling somebody, oh, you look like a snorer.
But in a country, in a setup like ours, where as it is the awareness is low, would that be sufficient if you think you're missing a frank OSA? Would you not try to ask him something maybe?
I feel that if a patient comes to you for a problem, it's far more compliant rather than when you put it up to him.
Okay. Anybody?
I think it's an interesting question because we tend to treat someone who comes with an ear problem, we treat the ear problem. Screening for OSA is debated, but there's some recent, there's a recent position statement from the Paediatric Academy saying that all children should be screened for snoring.
Yeah.
As snoring is the pathological hallmark of sleep disordered breathing in that population and in an adult population too. And I think it's about primary care physician education and general practitioner education. At that level, when they take a medical history, they should be screening for snoring and sleep disordered breathing and sleep disorders in their patients. So it probably should be a part of the screen medical history systems review done at the primary practitioner level to look for any associated disorders that go with the snoring.
I'd like to add to that. Our patients who come in have to fill out a questionnaire about their medical condition, their medications, their allergies, and I'm sure most of you do the same thing. One of the things that you will not find in a generally available form like that is a line about snoring. And I think we need to add that. We have it in ours, and then if they say yes to it, there's a backup where they then have to fill out pretty much close to an Epworth Sleepiness score and things like that.
It's an important point to note that the patient will often state this is a normal part of life. So they may sit in front of you or a relative may say, oh, that's just his snoring, that's just normal. To which my question usually is, what is normal about snoring?
I'm coming to that a little ahead.
Which,
I'll come to that.
And it's on a spectrum of disease. It's a matter of how abnormal it is. That's the issue. It's a sign of partial airway obstruction. It's a matter of how much airway obstruction.
We have to make sure that the patients understand that sound sleep is no longer good sleep. The sound sleep is something abnormal and it has to be investigated.
That's exactly what I would like to check with this next one is what are the issues that would raise a suspicion towards OSA for you in a patient?
I think number one is the history of snoring, and number two is I would be asking more questions to the bed partner.
Yeah. What kind of questions would you ask, Vidya?
The number one question I would ask the bed partner is, has she or he witnessed the apneic spells?
Yes.
That is the most important question that I would ask from her. I hope that the bed partner is not the dog that I saw in one of the slides that was shown before.
You can always hope for the best.
Yeah.
No,
and there are much more. I mean, I think you are going to discuss about it.
Yeah, no, I'm trying to get to the significant ones first because, generally a lot of us now who are here for this particular workshop already know what the basics of snoring and stuff is all about. So
the other important question that I would ask the patient himself is the excessive daytime somnolence.
Right.
How does he feel in the daytime? Is he feeling tired, drowsy, or if he is watching a TV or reading a paper, is there a chance that he would doze off?
So basically two most important would be a witnessed apneic spell by the partner or recorded apneic spell and of course the daytime fatigability and
daytime somnolence. Right. And there are multiple other questions. I mean,
I think as an add-on to that is sometimes you ask a patient how sleepy are you during the day and you get the answer not at all. And then you have to follow it up with a question, how much coffee do you drink? Or how much, soda? And you'll be amazed by some of the things you hear. The other thing I also ask is, you don't feel sleepy during the day, fine. How about when you come home and you're just sitting down and you have nothing else on your mind? You're done with whatever needs to be done. Your chores are done. Now what? And then the answer comes, oh, then I doze off. So falling asleep inappropriate times and in inappropriate places other than your bed in your bedroom, I think is a red flag.
So now, since all of you have said this, now the question would come to my mind as to whom would I ask this question to? Every patient of OSA that I'm kind of suspecting, Manoj said don't ask to people who have not come to you for that. So whom am I going to ask? I can't ask a person who's come into me, I know he's looking obese, he's looking the kind, he's come to me for a year discharge. Do I ask him for daytime sleepiness? Do I ask him for snoring?
At least every patient who presents for treatment of snoring should be asked that as a minimum.
Okay.
And it goes back to my earlier comment about educating the primary care physician about screening for these disorders. One slight caveat about tiredness and somnolence, and I'm not sure if Peter wants to comment about this, but there is a proportion of patients who snore who have no other features but have a significant degree of obstructive sleep apnea. And probably those patients do have a significantly increased cardiovascular risk. I mean, the evidence supports that in sort of, large cohort studies, the Bustleton cohort, things like that. I don't know if Richard wants to comment or Peter wants to comment about that, because there is some debate about having a significant degree of sleep apnea and just snoring, about whether you treat them as if they're relatively asymptomatic from the sleep apnea perspective.
I think the other important history is like what, in add-on to his point, is that around 75% patient with sleep apnea have hypertension, and my cardiologists have been screening this with their questionnaire that if they find a patient with hypertension and they don't find other answers, they ask the question, do you snore? And if they say yes, they are sending in to me
an important
for
aspect.
my
That's an
referral.
important aspect. Uncontrolled hypertension, mostly. Uncontrolled hypertension and uncontrolled diabetic being treated by the best of physicians with the right medication, still not coming under control, should ring a bell of an underlying OSA. And brings me to the question that, sorry, do you want to say something?
I just want to pick up on one point, which is this daytime sleepiness, which is a common characteristic of people with sleep apnea and sometimes with snoring. And in literature and around Australia, we use the Epworth Sleepiness Score as a measure of daytime sleepiness.
I will be coming to that also.
Okay, I'll leave that until later then.
Yeah. So that's the point that Stuart made. Snoring, it's pretty common. Almost everybody does it. Culturally, it's not considered to be a disease. So what kind of snoring does one really give importance to?
Troublesome?
Yeah.
I think all of it, until we've proven it doesn't put the patient at significant risk, or they don't have significant quality of life problems, or they don't want it treated. So I think any patient who presents for the treatment of snoring has to have a detailed evaluation assessment for that snoring. And any adult patient that has snoring in my hands gets a formal polysomnogram or a level 2 study. So they need an evaluation, and the significance you attach to it depends upon how much risk they are at, combined with how much significance the patient attaches to the disorder.
Yeah,
so
but there's not much of that category in our country. They say that snoring is not important or significant, or he or she would obviously say it just happens occasionally.
If
so
it's
my question is the dictum that every snorer is a sleep apneic until proven otherwise?
Well, not necessarily, but they need to be investigated for it. They need to be worked up clinically and investigated for it. There is some work, and Peter was talking to me about John Wheatley recently, looking into simple snorers and whether there can even be an extension of to such factors as vibration of the main vasculature in the neck causing atherosclerotic plaques just from snoring alone. But we don't have any evidence that supports that hypothesis. We do have evidence that moderate to severe obstructive sleep apnea increases cardiovascular risk and other risks significantly, as we've discussed today. And so if the degree of sleep disordered breathing is less than that and the patient doesn't attach significance to it, it may be just a matter of surveillance and keeping a close watch on that particular patient without letting them go.
No, I totally agree, but I would request one of our Indian perspective part of it. So, it's like when you have so much of snoring, sometimes if you start evaluating for every patient of snoring, you would be accused of overkill. If you're going to diagnose and evaluate every patient of snoring in this country,
which
you're
is why
going to be accused of...
I agree, I got a point. Which is why I think we should put up, at least in my clinic, we have videos and we have pamphlets outside that give them information what a dangerous snoring would be, or what a troublesome snoring could be.
Right.
So at least in my state, people would read anything, so they go through that, and then they say that yes, I do have a problem. Sometimes they exaggerate, but it is a good starting point for them to realize that we're not trying to push anything onto you, but
Right.
you read and you find out if you have a problem, you come to us.
So it's better that they read up first.
Yeah, I think so. And I don't know about the Indian literature so far. We don't have the full data about Indian thing about the primary snorer incidence, but I think it's up to 10% in the world literature, the primary snorers, but the rest, but
probably
it was
more.
10 age and gender. So 90% of the snoring is maybe associated with sleep apnea or UARS. So you have to tell them or educate them that snoring is not just simple snoring anymore.
If you've got an issue with your colleagues claiming that you over-service or over-investigate this disorder, certainly in some other countries like I think Australia and probably the US, there should also be a concern of the contrary end of the spectrum, that if you don't investigate this patient, it could be a medico-legal issue that you haven't properly evaluated them and sorted them out if they present for the treatment of snoring.
Yeah, we're a bit far away from those medical legal issues in this country as yet, because we are still struggling as to try and get the awareness up. So now this is the common question that sometimes goes through a lot of people's mind. I mean, the louder the snoring, the worse is the OSA. What would you say? Your comments. Is this really true, or is this just a myth? The amplitude of snoring sound, has it got anything to do with the severity of the disease?
Myth is my answer to that. and there's been a few studies out there looking at the power spectrum of snoring, and it varies from person to person, and it varies based on anatomy to a large degree. And some people will perceive, high frequency, low amplitude noise as being more annoying than low frequency, high amplitude noise. And so, but all those things aside, I'm not aware of anyone showing a relationship between either intensity of snoring or loudness of snoring or frequency of snoring and any aspect of sleep disorder breathing. So myth.
I suppose, yeah. Now let's move to a bit of this, what you were saying, Peter, excessive daytime somnolence. How would you evaluate it, and how would you rate that? What all are the tools that you would get? Anyway, Peter.
I guess my first and probably only point on this was that I thought all the responses earlier saying, ask your patient if they have daytime sleepiness is probably the most discriminatory thing you can do to assess daytime sleepiness. In Australia, we use the Epworth Sleepiness Score, and it's been well validated in the Australian population. It was designed by a guy called Murray Johns from the Epworth Hospital in New South Wales. I'm not sure the Epworth Sleepiness Score is appropriate for an Indian population. I think it asks questions which may not be appropriate in this population, but I think that needs to be looked at. For example, not everyone in India drives cars, and that's an important aspect of the Epworth Sleepiness Score. So I actually think that at some stage someone should seriously consider testing and designing an India-specific measure of sleepiness.
I think in India we still follow the Epworth sleepiness scale. Just we modify the questionnaire. We just ask them, if you are sitting behind the car and somebody else is driving, is there a still chance of dozing or not? And then we take that answer, yes or no for that, But I agree with you. Like driving the car and dozing is more serious than a passenger dozing off while he is in the back. So I think we need to devise our own system. But in general, I belong to the same school of thought like Friedman. So we were doing the loudness scale by visual analog scaling, VAS 1 to 10. And number 2 is Epworth sleepiness scale. That is for the subjective, and the objective obviously is PSG.
This is a video which I am playing for somebody who asked in the morning about the objective evaluation and how the reaction time is. If you see this is what is the vigilance testing. You have a dot there which moves every one circle and then skips a circle and goes ahead. and the patient is put in a dark room with a trigger mechanism where he has to note that missing part, and then you get a sheet. I mean, that somebody asked in the morning, I kind of remembered this, so I just played that, sorry.
And it needs to be interpreted as such rather than a be-all and end-all. I think it's an excellent way to, like TK said, to communicate with other people. There's a couple of caveats. One is you can get patients with significant tonsillar-generated collapse who don't have significant transoral tonsillar tissue. So you do your flexible manoeuvres either awake or under sleep or both, and you see some tonsillar-generated collapse that often you can do a more limited operation in than what you think on transoral assessment. And the other caveat I've mentioned earlier about tongue position relative to gagging when patients open the mouth, I do find it useful to have a look at the tongue size as they open the mouth as described by Friedman, but then to modify it with 2 tongue depressors in and gently withdraw them when there's relaxed transoral breathing. So I think it's in context of every other bit of assessment. And I would urge people, the paper that we've had published in the Journal of Clinical Sleep Medicine yesterday, to have a look at that, but to read the outcomes carefully, because even though some of the Friedman grades did very, very well from a modified utricle P and coblation channeling tongue, and this is coming from the primary author of the paper, I'm not sure about the clinical significance of those outcomes relative to the statistical significance of those outcomes. So I still think, the majority of patients you want are your Friedman 1s and some of the 2s where there's significant tonsillar generated collapse for a modified utricle P with or without coblation or radiofrequency.
Right, now we've been discussing this, we've been harping on BMI since morning. Let's not get into the grading, let's talk practically. How important do you think this is? We obviously know it's important, but at what stage would you say that, okay, beyond this BMI, I'm not going to do anything? This is for the surgeons.
35, I would say, for the surgery. Anything above 35, I would be really, really skeptical, except for 2 procedures. One is tracheotomy, number 1 may be bariatric.
I think it's important to know what you're treating. So it has to be in context of what you're actually treating in terms of the degree of sleep apnea and other concomitant problems. If you're talking about operating for pre-phase or adjuvant therapy, I'm not sure that a BMI would stop me. So if someone has kissing tonsils like the chap that I showed before, or they have a severe deviated nasal septum or severe external nasal valve collapse, and there's no way they're going to wear CPAP without it being pumped up to 20 centimetres of water pressure, then I might operate on that patient to facilitate other treatments. If you're talking about trying to define surgery as a salvage treatment for failed CPAP, then once the BMI gets above 35, our predictability for that outcome decreases. So the ability to tell the patient that you are going to get X result gets less and less as the BMI gets over 35.
Yeah, I didn't want to get too specific with that. That's why I put a general operate, because it would differ from patient to patient. But yes,
I totally agree with what Stuart is saying. The only other thing I would say is, I think the point about the BMI is, one, also to inform patients about what reasonable expectations they can have from the procedure being planned, particularly if it's a procedure for sleep apnea. If we're going to undertake it, we need to let them know where we stand on it. And secondly, it draws attention to the anesthetic issues. Even if it is a simple procedure, nasal valve correction, or a tonsillar operation, I think it behooves you to demonstrate that extra caution because of that number staring you in the face, which I think most of us do anyway.
In those circumstances, then it depends upon how much gain you think you'll get out of the particular procedure, whether it's worth the risk of anesthetic.
The gain, the benefit out of that. But we do all agree that yes, higher BMI is something to be a little bit cautious about. We're not defining exactly what.
We should all be aware of it. We should all be aware of telling patients that our surgical outcomes will deteriorate in the future if you gain weight in the future as well. It's one of the biggest enemies of surgery.
Important part of the counseling, which we will come to. But we do know that yes, BMI beyond 40 is something that one would not want to touch and would probably require that. So, do we really investigate such a patient, or do you say, oh, BMI 40, you just go and use a CPAP.
They should be investigated by a respiratory physician, and sometimes even they need endocrinological evaluation if there's been rapid weight gain without obvious cause. But probably there's a proportion of these patients that have obesity hyperventilation syndrome that should have an awake arterial blood gas looking at the PCO2, because there are different treatments for device use in obesity hyperventilation syndrome. I don't know if Richard or Peter got any experience with adaptive servoventilation or those sort of therapies, but there's certainly, it's not the standard CPAP treatment in patients with obesity hypoventilation syndrome, which I think is defined by resting PCO2 of over 45 and a BMI over 40 and moderate to severe sleep apnea. That'd be right, Richard, the three.
Yeah, but this evaluation is even before what we as an ENT surgeon would do?
I think you need a physician involved in that for sure.
Earlier.
I think virtually a lot of these patients should be evaluated with a physician close by, but this one in particular.
Yeah, the teamwork that we all spoke about at the beginning, right? Now, how important is this, and why do we really need to know what is upper airway resistance syndrome? If somebody can, because I think we have not spoken since morning, so if somebody can just elaborate on this a bit, and then.
The upper airway resistance syndrome, as far as we go for ENT, is very important, because we need to find out there may be some people whose AHI may not be high, they'll be snoring. So we have to find out those particular patients, because potentially these are the surgically treatable ones.
Yes.
Where we think that we can do benefit instead of full-fledged OSA, we believe that CPAP is a gold standard. So, but these are the ones where surgery would really play a role. So I think understanding UARS is very important.
So that spectrum in between the snoring and primary snoring.
Primary snoring is somewhere in between, where we need
can
to
intervene the best.
Investigate and look at the airway, which level we are having the block. So those kind of evaluations, upper and lower airway, should come into play. Where we think that this is going to be useful for us surgically.
And I agree with that. I think they're probably all good surgical candidates. The challenge is actually defining what UARS is. And in my view, it's just because it's a phenomenon that doesn't meet the classic criteria for apnea or hypopnea, but you know something's happening. These prolonged periods of flow limitation, which is characteristic of a high resistance in the airway, which is otherwise unclassifiable. And it gets back to our earlier comments about snoring. Snoring is kind of one extreme perhaps of UARS. And the challenge we all have is how do you classify that? How do you say someone has a certain level of snoring or a certain level of upper airway resistance syndrome? And I think you have to go back to the sleep physician, the proper sleep study, the proper type 1 study to be able to assess that. So I think if you suspect UARS, then you need to have a more comprehensive analysis of it.
That's where I think Professor Allen could put in his inputs as to how the polysomnogram or the sleep evaluations would differ.
Well, I think everyone does it right now. We have to use airflow instead of just temperature changes, and so we have to use the air pressure sensors to do the recording. And you have to look for the flattening of the air, showing you inspiratory decreased flow. So I think most of the centers, I would suspect all of them in Australia, certainly most of the United States, do this correctly now. And I think that would be something, if you're setting up a program, you would be able to assure it was done well. I think it's a well-accepted standard.
I really struggle with the term, personally. I hate this term because it's a term looking for a home. I mean, where is it? Where does it? I mean, it's on the spectrum somewhere, but what are we actually treating? Are we treating the patient's snoring? Well, probably they're a simple snorer. Are we treating the patient's tiredness? I don't know that we can clearly define upper airway resistance syndrome that causes tiredness and sleepiness. I don't know if there's any evidence to support that, Peter. Are we treating the patient, the interesting patient who's sort of younger and has a normal or near normal sleep study, but they complain of choking and gasping at night? Do they have globus pharyngeus? I mean, I don't really know where this lives. I know it's somewhere on the spectrum, but I just don't like the term itself.
It's ill-defined. Yeah. It's a continuous spectrum, so there's no division line where you would call this as UARS.
Yeah, I'm not sure.
But how would you then suspect it?
Well, I try not to use the term if I possibly can, but
And of course,
I try and define what the patient's problem is, what's troubling them. And if I've excluded significant sleep disordered breathing, then I try and treat what's troubling them. If it's the snoring that's troubling them, then I try and treat it. If it's the tiredness or the sleepiness, then we try and treat it. If it's the choking or the episodes at night that they feel like they're waking up but they're not actually got definable sleep apnea, then you try and treat it. But when I say you try and treat it, I don't know what the answer is exactly.
One of the critical issues, though, in this, and that we certainly, as in the scoring rules also, is whether or not it causes an arousal. So if you have an upper airway, if you have an airflow resistance associated with an arousal, then we feel this should be scored. That it's the arousal itself that we're looking at as the significant event, and the number of arousals are what is going to relate to the consequences of the sleep disturbance.
Yeah, if it's causing enough sleep fragmentation that the patient's got a problem, then
but
I think we treat it.
that's our definition of what we're talking about in terms.
And there's no problem with a trial of CPAP to see if it makes the patient feel better, so then you might know better what you're treating. It's not uncommon for us. I know they don't have significant sleep apnea, but it's not uncommon for us in the milder forms of the sleep disordered breathing spectrum where there's a patient has some symptoms to actually have a trial of CPAP to help us diagnostically, to tell us that if CPAP helps, then maybe opening the airway up helps.
But even if you send these people back to a sleep laboratory for an in-lab study, what you need to do, the gold standard way of assessing this is with esophageal pressures. So you have to put an esophageal balloon down, which is not done routinely in hardly any sleep laboratories. So in the absence of that, you rely on effort from bands on the chest wall. And of course, the heavier someone's get, the more their BMI is, the less reliable any surface measurement is of true effort. So it's a really, I think it's important to be aware of the limitations based around both the definitions and the measurement of UARS.
The efforts that related to sleep also at night, yeah.
My problem is after the patient has come in complaining of, be it severe snoring or witnessed apnea, and a sleep study comes back with upper airway resistance syndrome, it's a kiss of death for us because the insurance is not going to pay for any procedure that we direct at this condition. So that's why we hate this.
It's not classified as sleep apnea. It's not classified as OSA.
According to the pundits at the insurance companies, yes.
Which we all are facing everywhere. We ran short of a little time, so we ran short of quite some time. So I will be going a little faster so that I would like the audience interaction at the end of it. I would probably stop a little earlier so that we can take some questions from your end. So if you have questions, please note them down and pass them on to me, and we'll see what we can take. Now, I mentioned about the treatment of allergic rhinitis in my morning talk, so I suppose if there is any difference of opinion, we'll just skip this slide. I mean, do you think that it has to be aggressively treated in a mild OSA, who might just be basically because of the nasal obstruction? So everybody agrees on that? Yes. So I think I'll skip this one. Now comes the next question, which is practical for us and a lot of people here. You've done your suspicion. You have decided that this fellow has come to you for something, you've suspected, he's agreed. What's the next step before he leaves your consulting room? Because you have to be giving him some answer, some kind of instruction. So what would you go on to?
I think McKay has given a wonderful talk on this in the morning.
Yes, he did.
So when you say sleep evaluation, do you mean polysomnogram?
Yeah, or a sleep study, or level 3, either of the two. That's why it's a broad term that I've used.
First three are essential, and I think the remainder are debatable. And you're going to have people that have see advantages and disadvantages in all those remaining 4 points and have significant relevance to their own practice. I wouldn't have any fear of a CPAP trial. There shouldn't be any.
So the patient moves out from my consulting and he's told that go out and fill an ESS form.
Well,
right?
actually, I get them to fill it out beforehand and I review it with
prior
them.
to seeing you.
I review it with them.
No, but that's in your scenario, Stuart, where they're coming to you for that.
In the waiting room, but I review it with them in the consultation as well, because some people have filled it out
prior to seeing you.
They may need some help with it. They all get a flexible nasendoscopy, no doubt, and they get supine and erect evaluation with.
So Manoj, you think this would be a good practice that when they are come and they've read those signboards outside, so you might as well fill out an ESS form before you see me? That's a better idea to do?
Yes.
Yeah?
I think so.
That's a better idea for all of us. You know, when you've got the patient to be aware and before he sees you, let him fill out the ESS form. So you're able to judge more when he's been inside with you.
I think somebody made a good point that it may be worth mentioning to them, although if they're going to do it, you've got to do the same every time they do it, pre and post intervention. There may be some value in having the patient fill it out as if they've got nothing else on. I think it was TK who mentioned that. And so I do suggest them, but what would you be like if there's nothing else on? And sometimes they'll change a 0 to a 3, and it just shows that it's open to interpretation, the Epworth Sleepiness Score. So whether you allow them to fill it out just as they would or without any explanation, or whether you say, look, I'd rather you fill this out before and after any intervention at your worst, and if you had nothing else on, I think as long as you're comparing apples to apples, it's
fair. I did notice none of the surgeons went down to the CPAP trials. So is it to be done or not done?
Yeah, CPAP trial is mandatory in patients.
When would we do this?
After they've been formally evaluated with a sleep study, a formal polysomnogram.
Okay.
I think we can't make a leap with what we have, with the levels of evidence that we have, to say that we can operate on patients without a CPAP trial unless we see gross nasal or upper aerodigestive tract pathology that would preclude the use of CPAP altogether. And I mean gross fulminant nasal polyposis, kissing tonsils that are projecting out of the mouth, something in the upper airway as per Scher's meta-analysis said 1% of these patients may have an abnormality of the upper airway pathologically. Unless you've got a gross abnormality of that, then they get a sleep study, and no one can criticise you for that, and no one can criticise you for trialling CPAP.
Oh, trust me, people can criticize you for anything, Stuart. Don't worry about that. So the best order I would say that should be done would be get an ESS done before he comes to you. If you have the scope there and then do a scopy with you in your clinic. And
do an oral exam, nasal exam.
Yeah, I mean, that's understood. Yeah, that's clinical and examination. If you have flexible there and then do it. If not, you ask the patient to get himself a sleep study done, followed by a CPAP trial done. And in between this, try to fit in a flexible scopy as per the equipment that's available to you. Are we kind of agreeing on that?
Yes. MRI and drug-induced sleep endoscopy help you, then you incorporate it into your practice. Cephalometry I use in patients with CT airway reconstruction protocol where I know
we're going to that.
Towards a major operation.
Right.
So what I do is that just before taking the patient for the surgery, what I have decided, anyway, they are in the operating room. I just use my flexible and do a DICE.
So you don't do you do a DICE at that time?
Yeah, at that time. Just before the surgery,
yes.
I would reconfirm
so you don't do DICE separately earlier?
No, I don't do it separately.
Okay.
I just before intubating, I do the DICE, and then I will reconfirm the collapse and the additional information, whether it is an anteposterior.
But then how would you have made your diagnosis of the level of obstruction if you haven't done a DICE?
With the Friedman staging, with the flexible endoscopy.
Flexible endoscopy.
Yes, and then on top of it, like if it is a multi-level, you know that you are going to go for the surgery. The only type of surgery what is going to be different is whether you are going to do an expansion or whether it's a zeta. What type of palatal surgery?
We'll come to that. Decide. Tomorrow is the day for our.
Okay, so that I base it on the table and change my plan.
I believe that we have to have a system of thorough investigation and open communication with patients and setting realistic expectations. What I mean by that is any test I order, I need to know what I expect as a possible outcome of the test and how it will change my treatment plan. So the problem I have with the approach of doing a DICE at the time of the operation is I don't have a way of waking the patient up and saying, hey, guess what? I was going to go after your palate. I really think we should add the tongue base. So in my practice, DICE has not found a way as one of the primary tools I use. I use it in patients in whom I have a conundrum where I'm not able to explain why my initial procedure or somebody else's initial procedure has not worked, and I'm not able to tell the patient honestly what I would do different. So that's when I use DICE, and I want to talk to the patient about the results before I tell them anything.
I think we should add to that list management in conjunction with a sleep physician. It probably should, it's an important point to make.
Yes. Now, a small little thing, I think Dr. Vijay gave the protocols from our Indian perspective point of view, that it is mandatory, or rather it is most recommended to have a PSG, and for those of us who may not have access to a PSG, at least it is recommended that you do a level 3 sleep study. Not much to discuss.
Can I just ask the panelists, would they agree if level 3 is enough? Level 3 is without an EEG, and we don't know whether the patient is sleeping or not. And is it like more breath holding? You get more apneas than what it is, and we may be treating.
No, we are not debating whether level 3 is better than a PSG.
No, we are not saying that, but is it enough? Is it enough for us?
From an ENT surgeon's point of view, yes. Does everybody agree to that? In terms of being able to tell us what is the apnea-hypoapnea index for whatever it is worth, for it to be able to tell us the respiratory efforts, the oxygen saturation, which is also 4 of the parameters that a PSG would give us.
I don't have a role for level 3 studies in my practice at all.
Okay.
I do mostly a level 3 study. But if I find that somehow doesn't correlate with what I think, maybe we order a football sonogram.
Yes.
But I think level 3 is fair enough for our kind of work. I think it's, I fully agree.
In our setups, I mean, it's better than not doing anything at all. You use it as a screening tool, and if you really think that there is something more beyond that, it is always advisable to go in for a PSG. The arguments can be never ending, but for all practical purposes, the 4 parameters that are given by a level 3 sleep study are exactly the same that are given by the PSG, and the reporting of these 4 parameters are exactly the same. So for practical purposes, I think we'll end this discussion here. We have, now you're going into the who wants to be a millionaire, the tougher questions coming in. So let's finish with the easier ones.
I agree with your comments. If there's nothing else, that's fine. But if you have any query that there may be other things going on, restless leg syndrome, insomnia, narcolepsy, or even positional sleep apnea, none of them are captured in a level 3 study. And I take
it does have its fallacies.
I think in his practice there is no role for level 3, and I think that should be the standard here as well.
But one of the advantages you have here is that most of you are interested in becoming educated to rule out these other disorders. So at least if you don't have anything but level 3, you should come to meetings like this and have people educate you on what are the differential diagnoses that are important, including circadian rhythm disorders, which are important, and narcolepsy. So I know what I'm impressed with is how much everybody here wants to know that and wants to be able to do that differential, and I think you can do that.
Thank you, sir. We are working towards that. We're trying to get those standards done. A CPAP titrated study, Peter? To be done? Okay, so now we've done with our physiological part of everything. Comes to the main important question from the surgical point of view. We have to identify that site of obstruction. We've seen the flexible scopies done. We've had discussions with DICE in the morning and everything done. So I think we'll limit this one to dynamic MRI. If anybody wants to add something, because I am the strongest proponent of dynamic MRI all across the country, and I was introduced to it by Professor Mohan Kameshwaran in a very light-hearted manner when he I was asking stupid questions about why it shouldn't be done. And ever since 4 years, I've been hooked onto it, and nothing has been spoken about dynamic MRI. So we'll just take that additional 3 minutes on this and speak about the differences. Anybody here wants to add something before?
Probably cover it in about 10 seconds. Shows promise, but we need more work to know its role. But certainly shows promise.
Yes, very promising, but we're trying to compare it with DICE so the audience gets a good enough, fair enough idea as to where they should be headed.
There's an inherent problem with comparing all of these comparative tests or assessments, and that we don't know what the gold standard test or assessment is.
Absolutely.
And with some other examinations, we don't know what that is either. I mean, no one's really proven that auscultating the chest is of value in chest diseases, but we know it's helpful. And so, again, it's all in the context of the patient and the other clinical findings. But yeah, I know Peter, with his airway interest, is interested in dynamic or sleep MRI, but I think probably needs some more work to clarify its role clinically.
Absolutely. When you said the same thing, I mean, the talk, when I started in the beginning, was a practical discussion. We don't have comparative studies. So practically speaking, the people who are interested in trying to get evaluating this, and if they have to know all the options with their pros and cons.
It might depend on access to theatres, access to MRIs, those sort of things.
They would not have access to MRIs or DICE unless they start taking the initiative to get there. And this is what we're trying to initiate here. We're trying to initiate people to start doing dynamic Vijay played a lot of those slides, so I'm not going to play those slides. a few important things about how it's done. That's probably the question that's coming to people's mind. It's very simple. Do it just like a routine MRI. It takes about 1 day in advance, sometimes once in a lifetime, I would say, to go and sit down with your radiologist, get this software and everything, the settings done, and then you can start sending your patients for a dynamic MRI late at night, post dinner, when the MRI machines are otherwise also not functioning. So you're not interfering with their routine business, and they will be more than willing to wait about half an hour after the patient is in the gantry and falls asleep. And that, I think, would be the most physiological evaluation in dynamic motion that you would get, as compared to the other ones where you would have to induce sleep. May not be that physiological. I have just a few, I've just put this up. So I'm just coming to that. We'll discuss it, because there's a big debate on this, which Srinivas said and we had, and the debate could go on for a long time. So I've just put it down in a little bit of a concise manner, that if what Stuart said, the patient consideration has to be the first. It's not about you and about what you're going to do. It should be about what you can do best in the interest of the patient without really getting into being too invasive. Now, if you look at I've just compared it with these few criterias. If you look at the ease of doing the DICE versus a dynamic MRI, you just saw what all was needed for doing a DICE. You need a full OT setup, you need everything, you need the bispectral index monitoring, you need your scopes, you need an anesthetist, the drugs, the OT stay, the 1-day admission, etc., etc. Whereas for a dynamic MRI, you're just advising the patient to go and get it done. The difference being, you're probably not actively doing something. As a surgeon, that's a little bit difficult for us to digest, but from the patient point of view, it's so much easier to get that dynamic MRI done. Look at the physiology part if you want to compare it. Both are unphysiological, right? There is no way to really know whether in the dynamic MRI, the recording that you had, the patient was really in the stage of sleep that you really need to evaluate, right? So both are equally unphysiological. You can find that out with a BSI, what these two are doing now with, Srinivas and Vikas, but the problem is the same thing. You're not getting the exact information that you want. There are fallacies to that. The information that you get in a DICE is visual. It's recordable, but it's not correlatable post-operatively with the same. In an MRI, you have sagittal planes, you have axial planes. At multiple levels, you can have those axial planes. You can have the exact measurement of that airway at whatever step that you want, vertically or horizontally, and you can keep this as record and compare this post-operatively if you need. Whereas with a DICE, it's pretty much a subjective, your own actual visualization of the whole thing.
It's not nice to ask you a question back.
No, please do, because here
the MRI inherently has got a movement artifact.
The patient is sleeping.
No.
Postprandial at night, the patient is sleeping.
It still has movement artifact. So how accurate can you say our measurements can be?
I'll show you those videos after we finish. Right? Okay. The dangers, obviously the patient is undergoing simulated GA, whereas there's none here whatsoever. The objective recordings, the cost factor, if you want to compare, it's obviously you can't say that the dynamic MRI is more expensive, because doing a particular thing would probably be same or more expensive for those who do not have their own OT setups to do it in. The glamour, yes, DICE is very glamorous. You can feel that you've been actually doing something. Oh, I went there and I did this, and what a wonderful this I saw. It's glamorous, yes. But in the interest of the patient, what is something that I leave for you to decide. And of course, you don't need the admission in a dynamic MRI. So this is not about this being better than that. If people can start doing DICE, and if they think they want to do it, yes. You must get everything. Don't just do a simple, get a bispectral index, do all that, yes, get information. But for those who probably may not want to do a DICE, or probably when you have an option of getting some kind of an information, much simpler, much easier, only disadvantage being you are not actually doing something. But that again is wrong, because the films that come, the recordings that come, the measurements are something that you have to analyze. You are not going to rely on the radiologist to tell you something. You are going to compare those airway diameters with you, and you are going to record them with you, and you are going to record them later on. You are not going to rely on what